Okay, we'll get going. Well, welcome, ladies and gentlemen, to this, the March Worcestershire Acute Public Board. We've had a busy morning already, covering a range of topics, including a very interesting patient. And everyone involved in those networks, but also to encourage more staff. And I know it's sometimes difficult in the busy working day to get involved in networks that they feel would work best for them. We were presented, though, with some pretty sad stories of members of staff and colleagues who feel excluded from being able to be their true and authentic self because of a fear of being challenged or criticised by other colleagues or members of the public. And as chair of the board, I just want to emphasise I am proud that Worcestershire Acute is a inclusive and celebratory inclusive organisation where we focus on three key aspects: the competence of individuals, how hard they work, and the values that they live and act by. And therefore, when we see colleagues being affected by whether phobia or any sort of discriminatory actions, we want to call that out and say that is not us. We are proud of celebrating all of the various different and rich diversity of talents we have within our organisation. We have apologies from Colin today, and we currently have apologies from Glenn Burley, who's on a national call. And just before we get into the rest of the agenda, members of the public may not be aware, but Glenn has been asked to become the Financial Reset and Accountability Director for the NHS for a period of at least 9 months, but potentially longer. And so we have this morning announced that we are putting in place 2 acting chief executives to become the accountable officers for Glenn whilst he undertakes that important role. And I'm delighted that Stephen Coleman has been appointed to that role for Hereford and Worcestershire. So I think that is good news for the Trust, good news for the citizens of Hereford and Worcestershire, and I look forward to working even more closely for Stephen in that new role. And we wish Glenn well in his new role. We will be seeing him because he will continue to be the Foundation Group Chief Executive, and we will see him at the 4 board meetings. So the last set of minutes of the meeting held on the 3rd of March. Were there any points of accuracy? Could you please raise a digital hand for me, please? Ali, thank you.
Thank you, Chair. My attendance isn't recorded on the minutes, but I was in attendance at the meeting, if that could be rectified, please. And also on page 3 of the minutes under workforce, the opening line for that section says, as a result of a successful business case, we have establishment growth. However, I think that misrepresents actually what is a rebaselining of establishments and growth across a number of areas. So if we could remove the line after a successful business case, I think that would be more accurate. Thank you.
Okay, super. Thank you. We can make those adjustments, please. Joe, any other points of accuracy, colleagues? And then in terms of the action points arising, I think they're on page 7 of the pack. And it was an update on telephony provided to the Trust Board. Rebecca, can you just remind us where we are with this, because it's gone to the just to put it out for public purposes.
Yes, thank you, Chair. So BT are phasing out the public switched telephone network, PSTN. We've got work to do around that. So we've conducted an audit. We've got 100 analogue lines, and we've got a plan with our capital this year and next year to replace those with more modern telephony.
Okay, super. Thank you, Rebecca. Any points on matters arising colleagues feel I may have missed? Okay, we'll move on then to the Chief Executive's report. As I said, Glenn has had to be called into a national meeting, so I will take these as read. But I think the key takeouts of them for members of the public is there is an awful lot going on in the NHS at the moment. I think it's very good news for Worcestershire Acute that our Chief Executive, Glenn, has been asked to get involved in this role. And as this is the last day of the 24-25 financial year, I do want to thank and congratulate the Trust Management Board for delivering their highest ever cost and productivity improvement plans over the last year. I think that, I'm sure Neil will go into detail, as will Stephen, but I think that is an extraordinary result. And certainly in terms of confidence levels as we enter next financial year with demanding targets that we have to say, based on the finance and performance meetings that I've been to, that my assurance level is higher than it's ever been. So really well done, colleagues, and please pass our thanks on to everyone else. But Glenn also pulls out the 25-26 planning round, which is on the agenda for later. But I'll invite any questions on Glenn's report, please. Simon?
Thanks, Russell. I think it is worth recording on the public record the huge improvement that has taken place in our cost efficiency programs since this trust joined the foundation group. Historically, meeting those targets which we'd set ourselves in terms of efficiency and savings were very difficult and were never actually met. The transformation in the past 12 months in particular, since new ways of approaching these targets have been introduced, has been remarkable, and I think it is worth recording. And obviously thank you to all the staff who've made this happen. But I think the cultural shift that's taken place as a result of Foundation Group membership has had a key part in those targets being achieved.
Thank you, Simon. Any other comments on Glenn's report? Okay, and thank you to the teams which are called out in the last section of Glenn's report. We'll move on then to the detail of the integrated performance report. And Stephen, what would you care to pull out in your introduction?
Yeah, thanks. And I guess I'll use the opportunity to do a bit of a bridge between Glenn's report and the performance report that you've got. Bits that I just wanted to pull out, I think we were trailing it before, now you start to see it come through the numbers, are the improvements around a number of our urgent and emergency care target, in particular the noticeable improvement in ambulance handovers, which we had a real focus on. There is still more to do, particularly patients waiting a longer time in the department, over 12 hours. Inextricably, when we get to the planning round, that's the focus of flow. That whole thing still rings true for this trust and as a system, but there's some real efforts gone in there, and you can start to see that improve. Similarly with elective and cancer, I think we are generally holding our own. There's still some noticeable improvements that we need to make that Chris will talk through, and a focus for us really with the financial plan as well as around the productivity. And I know Chris has got a number of ways of schemes that he's looking at how we will deliver that. Again, as been mentioned, the finance, we will talk about this for the year end in the next one, but it's really pleasing to see that we've hit our financial plan, and again that's largely down to the work of the divisions and Neil's teams and others working together to deliver that, so we're really pleased about that. And in terms of quality, there are still some areas that we've really got to focus on, particularly around our IPC and some of the areas that have been a bit stubborn for the trust, I think it's fair to say. So some of the sepsis compliance, But really pleasing, because I know that it's been a focus of the board and that we've been trying to improve, is around complaints management. I know we've got a new complaints manager who's doing a really good job, and it's pleasing to see that move. And then to link it with what Simon said, what was really, really pleasing for us in all of this is if we look at our staff survey results that Glenn mentions, particularly where it's staff recommending it as a place to work, third most improved nationally, our response rate was significant. That said, as brilliant as that is, we're still in the pack, and we want to be better than the pack. So we're using it as a really good foundation, awful lot to go at. We need to keep that cultural shift really moving to deliver next year and to do it in the way that colleagues would want us to do. But that's my summary, and happy to take questions. Others will pull out more of the Z behind it.
Okay, thank you very much, Stephen. Great staff survey results and context. Any questions for Stephen, or should we dive into the detail? Can't see a digital hand raised, so we'll move on to Chris. Chris, how are you seeing things? How's the engine doing, so to speak?
Thanks, Chair. So I'll take the report as read. A few bits I do want to pull out though. So from a cancer point of view, faster diagnosis standard, which means that a patient's being given a diagnosis within 28 days, is 80% for February, which is effectively the national ask to deliver by the end of March 2026. So we're doing really well in that regard. The bit that relates to that, though, that isn't necessarily drawn out in the pack, is that for those patients who have a cancer diagnosis, we're telling 60% within 28 days. Now that's still not in line with the 80% target for all patients who are referred and with suspected cancer, but actually compared to March last year, when we were at 44%, it's a significant improvement and puts us in a good stead in terms of delivering some of the other access to cancer treatment we want to. 62 days, though, which is the target for patients to receive their treatment from referral, is at 60% in February, which clearly isn't where we want it to be and has taken a bit of a drop in recent months against a target for this year of 70%. So still more work to do there, mostly driven by improvements we still need to make in our skin pathway, as well as some challenges around the breast pathway and urological cancer pathways. So there are plans in place to address some of that, but I think the challenge I'm particularly concerned about is the speed at which we can recover the skin cancer pathway, given it's been a bit of an Achilles heel for us for a number of months now. But we are working with our colleagues in Wye Valley and with the ICB around a sort of sustainable solution, not just for skin cancer, but for dermatology, both across the county and across the ICS footprint. I think linked to that, 31 days, which is the time for treatment, having had a decision to treatment, still more work to do in there. There are 4 tumour sites that are less than the target of 96% though. So skin is one of those, along with breast, lung and urology. So I think it links really clearly to our 62-day performance in terms of where we need to make those improvements. Some of that has been driven by the fact that for skin in particular, we have been clearing a backlog that's been built where we've had a lack of capacity, and an unexpected spike in referrals for skin cancer in January, where the number of referrals was more similar to that we would expect in the height of summer. If I can move on to elective performance. So we do have one patient at the end of February waiting more than 104 weeks. And that was due to an administrative error, which has been fully investigated by the team. And we will be doing the full harm review process for that patient, given they've been waiting for so long. They're now with another provider waiting for some further diagnostic tests that we don't perform locally. So there'll be a further update to board next month. But in terms of the review of the systems and processes in place that related to the issue, that has been concluded by the relevant division, and a report will be forthcoming through our trust management board. But I'm assured that there are now more robust systems and processes to limit the opportunity for that to happen again. We do have a small cohort of patients over 78 weeks. Other than the patient who's waiting 104 weeks, those almost all relate to patients waiting for corneal transplants, and they are dependent on the provision of transplant material from the NHS Blood and Transfusion Service. And then in terms of 65 weeks, still not at 0, which is where we wanted to be by the end of the year. That said, an improving position again into February, but we are unlikely to be 0 by the end of March as well. As in previous months, those areas impacted have been oral and maxillofacial surgery, general surgery, and ENT. And ENT continues to be a challenge into the new financial year. Looking ahead, based on our demand and capacity modelling, in terms of eliminating 52 weeks, which is the big driver for next year, alongside improving our 18-week performance, ENT, which is ear, nose and throat, trauma and orthopaedics and pain management are flagging as areas of concern, but the teams are now working on their plans or finalising their plans as to how they're going to deliver that within the scope of the capacity they've got in-house, in terms of how we're going to use the capacity differently, because clearly going into 25-26, much more focus on productivity improvements, reducing or eliminating insourcing and outsourcing solutions that are costly to the NHS. So talking about productivity in the elective space, clearly lots going on linked to the Getting It Right First Time, or GERT Further Faster programme, that has helped us to improve the percentage of patients waiting over 52 weeks at the end of the year. And in terms of outpatients, because clearly that's not a good use of capacity when we don't perform operations or see people that we're expecting to see on the day, but also it's not a good patient experience for patients to turn up or to have their appointments cancelled at short notice. And a real opportunity in terms of how we can make things better for patients, but also how we can be more productive in terms of the capacity we've got. I'm also really focused on the number of patients that we're treating on theatre lists and standardising the number of patients we're seeing in our outpatient clinics, but giving them the due time they need to be seen. And we're doing some work around right procedure at right place, which is making sure that we're seeing those patients in theatres who really need to be seen in theatres, but where we can perform their procedures in other clinical settings, we're doing so, which means we can make better use of our physical estate. And then lastly, then, the big challenge operationally is around our urgent and emergency care performance. Stephen's alluded to, we are starting to see some improvements in some of the performance, particularly around the number of patients who we hand over within 45 minutes. And a small improvement in our emergency access standard. Challenges though, we are still seeing, we've had our national tier 1 visit at the end of February, so we've been escalated into national tiering. That's highlighted 3 main areas that they're going to support us on as a system. So one of those is the community hospital length of stay with our partners in the Health and Care Trust, and how patients access beds in their community hospitals. The ED workforce model and the systems and processes we have in our emergency departments to make sure that we're able to see as many patients as quickly as possible within the capacity we have available, and the frailty model across the county in terms of what that looks like, including links to establishing a virtual hospital work being led by Sarah as the chief nurse. That said, there is some excellent work we're already doing, and we've been showcasing regionally. So the ambulance pit stop on the Worcestershire Royal site, which is diverting a good percentage of patients, who are seeing 35 to 40% of patients on most days who pull up to the pit stop being diverted to an alternative to the emergency department. The community general medicine model, which is enabling patients to access beds in our community hospitals for fractured femur patients and older people. So that's an overall shorter length of stay, but we are still seeing too many patients with no reason to reside in our acute hospital beds. That's about 110 patients on any given day who don't need to be here, and about 70% of those are waiting on external actions. And then just finally, just to draw to everyone's attention, that in terms of the February discharges, against the current target for discharges, our simple discharges, we achieved over 100% against the target, and the complex discharges, it was just shy of, it was about 95%. So more work to do on complex discharges through pathway 1, 2 and 3 with our partners. Nothing else to add. Thanks, Chair.
Chris, that was a very comprehensive overview. Thank you very much. Clearly an awful lot going on and progress being made, but a lot more to achieve. Any questions or perspectives to Chris? Chris, just you touched on one of the things I was going to ask you about, but just quickly, it was, I think, implicit in some of the things you said, but we have been talking about rebalancing work across the 3 sites, in particular using Kidderminster more actively. How's that going?
Still more work to do, Chair. I think the right procedure, right place is enabling us to do more of that in terms of using the treatment rooms rather than theatres across, particularly in Kidderminster and at the Alex, to rebalance some of our elective work, but also some of the ambulatory trauma. So people are able to walk in or to come in from home for things like upper limb trauma surgery that can happen elsewhere other than on the Worcestershire Royal site. So work in progress, Chair, but definitely progress being made. Okay,
and I don't necessarily expect you to have a fully formed answer on this one, but it did come up in last week's Foundation Group subcommittee, which Stephen's aware of. There's some really good work going on down at Wye Valley on the application of artificial intelligence tools to drive particularly consultant productivity, to get rid of some of the admin processes they're having to adopt. I know work is going on at Worcestershire between your teams and Rebecca, but anything you'd like to say about the application of AI, just to give members of the public a flavour of some of the things we're looking at?
Yeah, I think there's lots of opportunity in terms of things we can look at here, and clearly keen to learn more from Wye Valley, but we are looking at opportunities around how we can make sure that our theatre lists are fully utilised, that we've got patients booked in the right order and to fulfil that theatre capacity, which can be supported by artificial intelligence. We've also done some work with Rebecca's team around looking at those patients that do not attend appointments, so we can do some focused work with those patients to make sure that we're supporting them to attend or to understand why they can't. Loads of other opportunities that the team are working through, but there's just a bit of a flavour of some of the things we're starting off to do now.
That's great, Chris. And just a bit of a shout out for our volunteers involved with the pharmacy running work around the hospital. Really good progress on there, isn't there? Chris, you can say something if you like.
Nothing really to add, Russell. Clearly the work on the pharmacy runners and other volunteer opportunities we've got around the DNAs and how we use our volunteers to do other things that we can be supported by some of the AI work. Lots of, like I said before, lots to go at. But I guess the more volunteers we can get, the better, Russell, because I think there's lots of opportunity. So anybody out there, please do reach out.
That's super, thank you. Simon, then we'll move on.
Just on the pharmacy volunteers, I did go on a session for a couple of hours a couple of Fridays ago, and it was absolutely fascinating. And while I think there is always a need for more volunteers, I think for us as a board, there is a cultural shift, particularly on the Royal site, that needs to take place, because I was under the wing of a very experienced volunteer. We went off to the patient discharge land with medicines for somebody to leave, and that probably took us 4 or 5 minutes from going pharmacy to that ward. By the time I came back, I said to one of the pharmacy colleagues, how many nurses came to the window to collect medicines? And she said about 10. Now, volunteers should be able to replace every single one of those nurses who've come from a ward to pick up the medicine. But I think it needs to be a push as well as a pull. We need the wards to be aware of that. We need leaders to be leading on this, saying, use these volunteers, because they will save us so much time. Clinical time. So it's a great system. I think the potential is huge. It's going to go to the Alex in June and July, and I think the Alex might find it a bit easier because it's a smaller site, but for the Royal, there's a huge opportunity here.
Yeah, and as Karen says in the chat box, huge well done to the team. Okay, guys, we'll move on then to quality and safety. Thanks, Chris. Thanks for your hard work. Please thank your teams for us. On to quality and safety, Sarah and Jules, over to you.
Thank you, Chair. So pleased to say that in February we are beginning to see a reduction in our C. difficile numbers, and I think this is the work really that we're doing around improvement and improved cleaning. The number of patients with flu did decrease throughout February and have continued to be managed by cohorting. And we've also seen reducing numbers of COVID. However, norovirus cases have continued to be a challenge and do still continue to be a challenge in March. We are seeing improvements, as Stephen noted, around our complaint compliance target. And although we didn't meet our 90% in February 25, what we are seeing is a reduction in the number of open complaints. So the up-to-date position as of March is 90 open complaints from 124 in February. In February, we had 46 breach complaints over the 25 days, and we are now down to just 20. The division which has made the most improvement is surgery. So surgery have now just got 4 overdue complaints, and they are due to be actioned by the end of this week. Pleased to say also that the number of falls are reducing, and we've had no falls which have caused serious harm throughout February, and also the reduction of hospital acquired pressure ulcers is also showing a continued month-on-month reduction, which again kind of does reference the number of improvement projects that we have had in place over the last 3 or 4 months around our tissue viability. We will note around our friends and family recommended rates have failed to meet the target of 95%, but there is focus work going on across these areas. And some of our numbers of people completing the survey, we are anticipating is due to the introduction of our inpatient surveys, where every ward completes 50 surveys each month, which has given us a real richness of information and for us to act on quickly. So I will hand over to Jules.
Thank you, Sarah. Thank you, Chair. Only thing I wanted to highlight, Chair, was the work that we are going to be refocusing around our trauma improvement group. The other elements I'll obviously have the report take as read. Those eagle-eyed amongst you will notice there isn't an ecopHEMA slide this month, and that's because of the restructuring we're doing in that space. A whole new kind of action plan and a group that will be reporting into our internal urgent and emergency care recovery board to try and get some movement and some traction for that group of patients. That was the only thing I wanted to highlight. We'll update on that formally next month.
Okay, thank you, Jules. Questions and perspectives to Jules and to Sarah? Jules, just one for you, just in terms of how our consultant and junior doctor colleagues are feeling about things. Is there a real desire, do you feel, amongst their cohort to seize the opportunities of AI as Chris and Rebecca and others bring them as opportunities?
Absolutely, Chair. We've seen lots of, been approached by lots of colleagues with ideas and things they want to do in that space in terms of innovation. And I think there is a huge opportunity, as Chris has said. So definitely an appetite amongst the clinicians to explore those and to try and get some efficiencies, and which will translate to better care for our patients.
No, fantastic, thank you. And just a call out, which I should have mentioned earlier, on what we discussed this morning at the board workshop. We did, I said, talk about procurement, but I want to have a shout out to Sanj, our head of procurement, for the work he's doing in terms of comparing the opportunities for cost savings and productivity. We'll move on then to workforce, given there are no hands raised. And over to you, Ali. What would you care to pull out? Thank you, Jules and Sarah.
Thank you, Chair. I'll take the detail of the report as read, but to highlight positively, first of all, we see continued positive improvement that indicates workforce stability in terms of a low number of vacancies. We are successfully recruiting to the vacancies that we have. We're seeing areas such as consultant recruitment show real improvements and popularity, shall I say, amongst our consultant vacancies now, with people actively seeking to come and work with us. We also have low staff turnover as well, which is all really positive from keeping that stable workforce in place. Board members and members of the public may then ask, why do we have the agency and temporary staffing usage that we have? And I think it's fair to say that remains a significant concern for us, because we know that agency dependency and spend far outweighs the number of actual vacancies that we have. And I think, as people will see from the pack, that's largely contributed to by some of that additional pressure that we have within our system. So where we are nursing for people in corridor spaces, for example, where we have exceptionally busy urgent care departments, we see that we have that long-term dependency, and we can see that through some of the length of service of some of those agency workers in those areas. That's not just to say we're wholly reliant on agency. We do have strong reliance on bank in those areas as well. But all of that is adding that extra cost into the system and extra pressure. And it's fair to say we would much prefer to be able to rely on a substantive workforce base to be able to staff those areas as well. There are still things that we can do to reduce that expenditure. A lot of that work over the past year has been around how we contract with our agencies. So making sure that we don't use off-framework agencies, making sure that we stick to the agreements of the West Midlands cluster, which focuses on keeping a cap on those agency fees that can be charged to trusts as well. But needless to say, as a percentage of our gross costs, the agency cost is far too high at the moment, and it remains a significant concern and an area of focus for us, particularly as we go into this year's annual plan and have some really clear objectives and opportunity around reducing that agency going forward. Aside from that, I think the other area of concern that remains for us is around sickness absence for our colleagues, particularly stress-related absence. That will often be a mixture of either domestic stress or work-based stress. It's often hard to differentiate what the stress-related absence is for, but it's fair to say that in some areas, 30 to 40% of colleagues who are off sick reporting that it's because of mental health reasons or stress or anxiety, depression, that remains an area of focus for us. We do have quite a comprehensive wellbeing package. We've recently opened another wellbeing space at the Worcester Royal site to complement those in place already at Kidderminster and at Redditch. And there are other things we are exploring around things like financial wellbeing for colleagues and how we can support people holistically with their health and wellbeing. So that again remains something that, as for our people strategy going forward, is a major priority for us to make sure that we're doing everything we can to support the people to stay well and at work. And the other area of focus is continued work to try and increase the number of compliant job plans that we have in the organisation. We've seen a very small increase this reported month, but there is still work to do there to meet the target that we need to of 90% for those consultant job plan compliance as well. I think that's all I'll highlight at this point. The rest of the detail is in the report, but happy to take any questions.
Thank you, Ali. Questions or perspectives to Ali? Simon?
Just to add on the staff health and wellbeing offer, the charity Declaration of Interest, here I chair the charity, has recently agreed to fund a pilot for massage for staff across all 3 sites. This was very popular a few months back when it was done for Health and Wellbeing Week. And as a result of that, it's now going to be rolled out on a pilot basis across the 3 sites in April, with a view to it then becoming sort of a standard offer that we can make to staff at any time of the day. I mean, it'll be structured, but nevertheless, night shift as well as during days, particularly for clinical facing staff, but not exclusively.
Okay, thank you, Simon and Tony, and then we'll move on.
Thanks, Chair. Ali, I noticed that there's now a 95% national target requirement for job planning. Can you explain what the consequences are if we don't hit that target? Have they been laid out in any way? Thank you.
Broadly, although we haven't seen the impact of that yet in terms of how that will be managed, and I think with the national changes at NHS England, it's fair to say I think we're unsure as to how that will what that will look like for us if we don't meet that target. So yeah, at the moment our focus is purely on just trying to increase those numbers, but I think along with a number of other trusts it is a significant challenge for us. There are, I think, for us more opportunities as a group there in terms of how we learn from other trusts within the group and how we share some of that best practice as well. I'm not sure, Jules, whether you've heard anything more that you want to share around the failure to meet the target.
Jules? Sorry, Jules, I missed that.
Sorry, no, nothing to update at the moment, Chair.
I think more generally, Tony, and it's a nice segue into the finance report, is we have suffered, and the team, I think, have suffered for a preponderance of targets coming out from the centre, and I think they will, under Glenn and Jim Mackey's work, be slimmed down, and there will be far more incentives put in place for good performance, particularly financially, and consequences for poor performance. So I think we are going to move into, frankly, a more simpler, more targeted world of if you perform well, you'll see that on the bottom line, and if you don't perform well, your poor performance will be exposed. Can I ask all colleagues to go onto mute, because I'm hearing some background. Thank you, Ali. Thank you, Tony. So, Neil, literally today's the last year of the financial year. Do you want to pull out the key highlights?
Yeah, thank you, Chair. So yeah, we've seen a slight upturn in the month, positive performance again, very much in line with the forecast that we set ourselves a few months back, which gives us great confidence in the team's ability to project. Still a few risks to manage in the final month of the year, which I'll be discussing over the course of the next week as we close down the financial year, prepare the set of accounts. A few of those risks sit with the ICB, so we'll be having a conversation with those over the course of the next few days, come to an amicable position on those. Just pulling out a few of the key areas from the report. So we've heard from colleagues around management of winter, the excess capacity, and that has featured heavily in respect of the variances on costs, certainly. Winter pressures currently sit at 2.1 million against the budget that we'd set aside at 2.6. So it's likely to be there or thereabouts, if slightly overspent at the end of the financial year. However, we are struggling to get out of that capacity at this point, so those costs will continue into next financial year and feature as part of the plan. I'm expecting a business case to come back in that respect. Fixed price drugs, you'll see there's an overperformance against the fixed price contract that we've agreed with our local ICB, £3 million, and again we'll need to manage that as part of next year's contract, because there's a similar challenge in that respect into next year. Strong performance on the CPIP, as you mentioned earlier, Chair, and I'm hopeful that we will be able to deliver the whole the CPIP. There'll be some non-recurrent mitigation in order to do that at the end of the financial year, but certainly hopeful that we'll be able to tick that box as well, which would be great. Our cost per weighted activity unit, again driven by some of the winter costs, has gone down. So our weighted activity units have gone down, our costs have gone up, so we're 3.3% higher in January in terms of our cost per weighted activity unit. Does need to be an area of focus into 25-26 with a significant CPIP, even more challenging than this financial year, of course. Wanted to touch on capital. We, as we do most years, see significant slippage on our capital programme. So we've got an awful lot that we'd have to spend in March. I'll know next month how much of it we have actually spent, but it's looking very promising that we'll have spent most, if not all, of that capital programme. So again, some strong performance in the month to make sure we've got that managed. It does, however, mean that we've got a significant cash balance at the end of the financial year. We're going to have somewhere in the region of £30 million worth of cash at the end of the financial year. Happy to take any questions on the back of that, Chair. Thank you.
Thank you, Neil, and thank you to your team for overseeing a lot of the financial performance this year. Any questions or perspectives to Neil? Okay, so it's all about 25-26 now, Neil, so come back to that again a bit later. We'll move on to the perinatal safety report. Justine, lovely to see you again. What would you care to pull out of your report?
Thank you, Chair. So I'll take the paper as read. Just a couple of things that I wanted to highlight. Again, sadly, we didn't meet our 12+6 booking KPI. We're about 1% off, which is disappointing, but almost there, and I'm happy to report that there was no harm caused as a result of that. You'll see there that some of our workforce KPIs aren't where we would like them to be. Sickness is still much higher than we would want it to be, and there's an area of focus with our HR business partners at the moment. And our support worker turnover is a lot higher than any of the other groups in our teams. So there's some focused work there as well. Training generally is on target to get to where we want to be. A little bit of challenge with our medical staff. Sadly, we reported 3 stillbirths and a neonatal death in month, and obviously I'll talk a little bit more in the private board about the detail of those cases. But broadly speaking, our rates are still below the national average. We do, as Ali's already talked about, our consultant workforce has increased, which is great to see, but we still have those issues within our own middle grades, and there's some mitigation in place to make sure that those rotas are safe. Heat map wise, you'll see some changes there again, score a little bit higher than we'd like it to be. And again, that revolves really around those support worker vacancies and an increased stakeholder outlier issue with our ODN colleagues around delayed call clamping for preterm babies, which I am happy to report that our performance in the last 12 months has been much better, and I expect that to be removed quite quickly. We still wait the outcome of our submission of our CNST evidence, but hoping that in next month's report I'll be able to report positively about that. Happy to take any questions, Chair.
Thank you, Justine. Our heart goes out to those families who have lost a beloved child. Questions or perspectives to Justine? Okay, thank you, Justine. Fingers crossed on the CNST. We'll move on then to the safe staffing report, and we'll do midwifery first. Justine, back with you.
Yeah, as I've said, the sickness isn't where we want it to be. We've got a focused line by line walk through with our directorate teams in 2 weeks' time. So hopefully we'll have the assurance that it is being managed appropriately and staff are being supported wherever we can support them. Vacancy, you'll see, continues to fall for midwives, and we've onboarded all but 2 of our final cohorts of new starters. The final 2 are expected to start mid-April, where we'll be in a really positive position. And we're about to go out to advert for the 6 missing support staff. You'll see that we are increasing the times that we meet acuity, and that's really good to see. We were safe on all of our shifts throughout February. And you'll see that ongoing increase in the number of women who are able to access birth on the birth centre because our staffing has improved so much. And that's all I wanted to say today. Thank you, Chair.
Thank you, Justine. I'll run and segue into Sarah on nursing safe staffing, then I'll invite questions. Sarah, over to you.
Thank you, Chair. So this report provides an overview of the staffing safeguards for nursing of the wards and critical care during January 25, with numerical data presented for December 25. So staffing on paediatrics, neonates and all adult inpatient area has been maintained at safe staffing levels throughout January. And that's despite the high turnover of patients and the fluctuating acuity that we have seen in Riverbank and in our paediatric A&E. There were 25 insignificant or minor harms reported in January related to safe staffing. We continue to be using all of our temporary escalation spaces and all of our boarding spaces on the Worcester site and corridor spaces in our Alexandra A&E. And we have managed to safely staff those areas in addition to our wards. Our care hours per patient per day remains within the national benchmark, and I'm really pleased to say that our vacancy rate for nursing is at 1%. So we currently have just 23 registered nurse vacancies in the trust at the moment. There is the cost associated with the agency and bank staff required for our extra escalation areas, and I'll stop there.
Thank you, Sarah. And I know Stephen and others are doing lots of work on improving flow out of the hospital into our community beds to try and reduce that requirement for boarding and excess use of wards for escalation purposes. And members of the public can be assured that over time that is going to be a real area of focus for us, working with our partnership trust colleagues to improve the flow into community beds, and then most importantly to get people home. Much better to be home than in a hospital bed if you've passed your acute episode. Questions and perspectives to Sarah or Justine? Glenn?
So, Sarah, the switch between agency and bank is obviously something that we've made some really good progress on over the last year. What's your view on the performance of NHS professionals from a bank perspective at the moment, and when is there a review point on that?
So, I mean, we have had conversations around NHSP, and we are set to have a further conversation, both Ali and Neil and I, around what we do moving forwards. We are still focusing on the agency to bank reduction, and certainly our off-framework agencies is reduced down to minimal, and that does continue a focus for us.
Thank you, Glenn. Any other questions to Sarah or Justine on safe staffing levels? Tony?
Thanks, Chair. Sarah, there's a mention in the report, and I know you say this is only on stats up to the end of January, about overnighting off SDEC at Worcester. Could you just give us an update? Has that continued on, or has that now ceased? Thank you.
No, it has continued on, Tony, and it's something which really affects our ability around managing the front door flow the next day. So that's something that myself, Chris, and Jules are looking at, but it's kind of a risk assessment around whether we use medical SDEC for golden discharges overnight as opposed to holding ambulances outside, and that's kind of the risk assessment that we make on a daily basis.
Thanks, Sarah. Thanks, Tony. Okay, Tim, we'll move on then. And Glenn mentioned it in his report. Stephen also mentioned it in his overview. But some pleasing progress on the staff survey results. Comprehensive details included in the appendix. But Ali, what would you care to pull out?
Thank you. I think really not to underestimate the pride and celebration that we are taking in this year's staff survey results. We've seen a huge increase in the uptake of the staff survey from previously 31% response rate up to 46%. And whilst that's still 2% behind the national average for similar trusts, for our organisation, that is a huge leap forward, and I think really represents a change and a shift in the culture of engagement that we're really trying to foster in the trust as well. And the efforts across all of our teams and all of our sites to really drive that commitment to engagement and drive that response rate was huge last year, and we're really seeing the results of that now. We've seen improvements across all people promise areas. People promises are the way that the questions are themed, and we've seen a significant increase in all of those areas, statistically significant across all but one, but across the board improvements. I think also worth pointing out is that we've seen increases to the engagement and morale scores that the survey gives us too, that have scored above the national average. This feels even more significant because those national averages haven't really moved. They've remained fairly static, but for our trust, we've seen that leap. So that's really encouraging. And as I think Stephen mentioned earlier, we are in the top 3 in terms of the most improved scores across the countries, recommending our trust as a place to work. It would be remiss of me not to, however, still draw attention to some of the equality data that's highlighted within the paper as well. And whilst we're seeing some improvements to people's reported experience in some indicators, it still feels wrong to celebrate an improvement in a shift in percentage where we're still seeing that people are reporting harassment, bullying or victimisation based on either their race or whether they have a long-term health condition or disability. We've seen a deterioration in people reporting an experience of bullying and harassment from other colleagues, and some reporting an experience of bullying or harassment or victimisation from members of the public or patients as well in circumstances. Positively, there are some indicators that tell us, for example, more people are getting the reasonable adjustments they need when they're working with a long-term health condition. but there's still a way to go, and there's still considerable focus that we need to take going forward to make sure that everybody is recognised and feels valued as an important part of our workforce, and everybody is treated with the respect and dignity that they deserve when they come to work as well to do the jobs that they do. So that remains a significant area of focus for us on a macro level. Within our divisions and our teams are now working on their individual heat maps that show where they've got areas of great success, but also the areas they need to work on. And we're really encouraging teams to focus on the 2 or 3 things that they can do to progress things significantly and do well, rather than trying to come away with an action plan of 20 or 30 actions that may not see the fundamental shift that people need. So we're encouraged with the level of engagement we've got. We're really focused now on engaging people in those actions, and we'll report back on how that's going as things progress as well. But overall, great news.
No, thank you, Ali, and I think all of the team should be pleased with the very real progress we're making. Still lots to go for, but as you say, Ali, none of our colleagues come to work to be bullied, harassed, be belittled, or made to feel bad about being their authentic self. So they are not values that we aspire to at all, and colleagues who are behaving in that way have no place working with us. Questions and perspectives to Ali? Glenn?
Yeah, I know you covered my report early, but well done everyone on the staff survey. The big one for me is the overall engagement score, and the regional analysis of that shows that we were the biggest increase year on year in terms of overall engagement, which then the evidence shows leads to lots of other things being right for our patients. So that's really positive. I think, though, this is about getting the balance right between celebrating the progress, but also recognising that there are still pockets of the organisation where we have scores that certainly need to be understood, and we need to do some work with the teams in order to improve them. So certainly in the way you explain that, Ali, that's the right balance that you're putting forward. But we need to keep on at this, because it will deliver everything else that needs to be delivered if we get it right.
Well said, Glenn. Thank you. And as Glenn often says, it is the most important metric that he looks at. Any questions or perspectives to Ali? Okay, so we'll move on then, without further ado, to the emergency planning, resilience and response. Rebecca, what would you care to pull out of this? And again, lots of detail in the appendices.
Yes, thank you, Chair, and thank you for receiving this paper. It's a requirement under the National Emergency Planning Core Standards, so thank you for receiving it today. A little bit of context in terms of being a public board. NHS providers are Category 1 responders under the Civil Contingencies Act, and that means that we have to have in place plans around what to do in an emergency, and we have to risk assess what emergencies might occur, and also we have to work with other local responders when emergencies do occur, and that's what this report is all about, telling us how well we're doing that. So 2 key points to pull out really here. First of all, under the national framework, our trust has been assessed as being substantially compliant, meeting 55 out of the 72 core standards, which is a continued improvement over the last few years. So a thank you and well done to our emergency planning team for their continued focus on that. And secondly, and this is the looking ahead bit, section 11 outlines our annual plan for emergency planning for the next year. We'll be looking to update our plans and standard operating procedures and have a real focus on business continuity at departmental level, and in my area in digital, and in particular cyber as well. We've also got some live exercises we'll be looking to run, and ensuring we keep all of our training up to date too. I'm happy to take any questions. Thank you, Chair.
Thank you, Rebecca. And there's, I know, an awful lot of work that goes on behind the scenes on this. Any questions or perspectives to Rebecca? Okay, so we'll duly note all of that hard work, but keep up the great work. Thank you, Rebecca. So we'll move on then to the annual plan. As we said, this is still a year of transition, which Glenn is going to be very involved in for the NHS totally. But Neil, what would you care to pull out?
Chair, if it's all right, I'll speak speak to this as planning comes under the portfolio of strategy, planning and improvement, if that's all right.
Apologies, Julian, it was under nil on the agenda.
I'm completely understood. Sorry, Chair. It may well be that Chris for operational, Ali for workforce, Neil for finance may well have elements that they want to comment on. But if I may, I'll just share with the board the final plan that was approved under delegated authority last Wednesday and then submitted to the ICB last Thursday, the 27th of March. I'll take the paper as read on the agenda, but just pull out the key points. So first of all, we have submitted a plan that's compliant with the performance metrics incorporated into the National Operational Planning Guidance. Secondly, as far as workforce is concerned, then the plan for the next financial year includes a significant reduction in our temporary workforce, both with our estimated 52% reduction in agency workforce, 15% reduction in our bank workforce, and a reduction in our infrastructure roles across the organisation to the tune of 116 whole-time equivalents. From the financial point of view, we have submitted a balanced or break-even financial plan, i.e. one that does not include any surplus or deficit for the forthcoming year. However, that is contingent on two things. First of all, a £47.3 million system deficit support allocation, and secondly, quite a challenging CPIP or productivity and efficiency target of £53 million, which is 6.6% of our operating expenses. Board members will note that this is an increase in £10 million for the CPIP target compared to previous conversations. That in part is contributed to the fact that we have increased our cost pressure because of continuing reliance on some temporary capacity, particularly with Avon 1 ward, and increasing the opening hours of our SDEC areas. And then secondly, there's a £6 million increase in the CPIP that we believe can be identified through system working and efficiencies that I'll come on to. Many of the risks associated with the plan were discussed at the Finance Recovery Board last week, and they include the need to develop further the efficiencies that are inherent in the plan, both internally around workforce and clinical service design. Members of the board will be aware of a whole week that we're focusing on improvements around the flow of patients through our hospital next week. And then secondly, and really quite importantly, the need for us to get involved in wider service changes across the system that we believe will net off some savings, both for us, but also for other partner organisations at system level. Thank you, Chair.
Thanks, Julian. I do just want to focus a little bit, just for total transparency, on that additional 6 million, because it does require us, Glenn, please correct me if I'm wrong, for us to take responsibility of that. We have been clear and maybe made ourselves a little bit unpopular, but the only way we can deliver that is by taking lead provider responsibilities for the community beds. Community beds in Worcestershire have a very high length of stay for a variety of complicated reasons, but the length of stay in community beds is 29 at the moment, and we believe for us to be able to take that 6 million improvement, we would need to see that dropping down to something much closer to 20 days, and we would take the lead provider responsibilities to help make that happen. Is that a fair summary, Glenn?
Yes, that's absolutely correct. And as you say, that there is an opportunity, and part of that opportunity actually has been flagged by a review from the National Urgent Emergency Care team, who visited a couple of weeks ago now, or maybe longer than that, and are about to give us some sort of steer on that. But certainly what we saw locally in terms of the length of stay for community hospital beds was one of the largest they've seen. So I think there is an opportunity there. And I also think if we move to a model that has less hospitalisation for patients within it, then there should be other opportunities on things like continuing healthcare spend in the long run. So it may come, that contribution could come from some other pots that sit with the ICS as well.
Glenn, just for members of the public, explain what lead provider means, please.
So we're not suggesting we're transferring the staff and the facilities into the acute trust, but what we are very keen to do is to be the integrator of those services and to take responsibility for the population health needs. So, and that's consistent with other parts of the group. So there's some good progress being made in Herefordshire on this with Wye Valley and in Warwickshire with Swift and George Eliot. So we've learned some things from doing that elsewhere, but it is about taking operational and clinical responsibility for the way that those beds function. And obviously working with the Health and Care Trust to employ the staff and run those facilities. There's almost certainly then a link into the community services themselves, because often the beds within the community hospital can be freed up by more access, more capacity in community services. So we'll end up working really, really closely with the Health and Care Trust on those also. It's these days it's pretty commonplace actually for acutes to be starting to get involved in lead provider arrangements for those beds, because they're so important. And actually admission avoidance through those community teams is going to be an important part of this also. So we'll be working really, really closely with them, and hopefully they'll be supporting us in what is quite an ambitious savings plan. Now, having gone through our record year in terms of delivering cost improvement, we've increased it further this year, but our approach, particularly in this area, will be to improve the care to patients by getting them home first and home earlier, rather than us just cutting services.
Thank you, Glenn. Thank you, Julian. Any other questions to Julian? Okay, so I think all that segues quite neatly into the hard work I know that's been going on amongst colleagues with some outside support on trust strategy. Julian, what would you care to pull out on the basis this is what I thought you were going to talk about next on the agenda? I think you've got some slides for us. Julian, over to you.
I do. Can you just confirm, Chair, that you can see my slides?
Yes, I can.
Thank you very much. In that case, with the Chair and the Board's permission, I'd like to share with you, and I'm quite excited to do this, I'd like to share with you the updated Trust strategic objectives for the next 5 years. I'll take us through where we were. So this is where we're coming from, whereby something based on the Virginia Mason pyramid was used to illustrate the trust strategy and strategic objectives in the past. The main drivers for change going forward had been locally, our renewed leadership and joining the foundation group. Nationally, we're operating in a new environment. There's a new national context with the anticipated new NHS 10-year plan. Thirdly, development of refreshed trust values led by Ali, our Chief People Officer, and then again locally, that emphasis on system working and collaborative working between and across organisations at place level. So looking forward, we wanted to reflect all those things in our trust strategy. What actions have we done, or what principles have we implied? Well, we've engaged both with leaders internally and external to the organisation. The aim has very much been to have a document that feels different, that it evokes feelings and emotions rather than depicts structure. We've always wanted to maintain alignment with the foundation group Big Moves, whilst recognising the anticipated elements of the NHS 10-year plan that have been highlighted or, if you like, signposted by the recent Darzi report, and that's a shift towards prevention and focus on neighbourhood health. Many members of the board will be aware of some of the process that we've gone through so far, whereby we've engaged with stakeholders both internally, including at board workshops, and then individually with chair, chief exec and the like. But we've also undertaken an awful lot of engagement with external partners at place level and across the foundation group. And what we've done has been influenced by insights gained from patients, either through representative patient groups or through the work that Ali and Sarah, our chief nurse, has undertaken through the Big Quality Conversation and the patient voice and involvement work. The outputs of that have been moulded both by the Trust Board and then particularly by the executive team. This is the document that we will be sharing with board's permission, both internally and externally, and it illustrates and details our purpose, our mission, our vision, and then detail about the strategic priorities that we will then create for the next 5 years. We have a template that will now sit underneath this, whereby we can create some detail behind each of the elements of the pillars of the strategic priorities. And in doing so, the intention is to outline the outcomes that we're working towards and then our key commitments for the next financial year. The next steps are to work with individual executive directors on each one of those pillars of the strategic objectives to get the detail and then be able to use that to craft and guide the annual plan for the next year. And then once we've done that, work with clinical teams to refresh their clinical strategies and work with those clinical services to help them understand the different things that they need to do to help us as an organisation achieve those strategic objectives for the benefit of the population. I will leave you on the final slide, which is the document that hopefully with your permission we'll be sharing more widely. Thank you, Chair.
That's great. Thank you, Julian. And I have to say, I've been very impressed throughout this process as to the quality of work that's gone on here. The board have seen most of it before. Any questions and perspectives from colleagues? Okay, I think so. Karen?
Yeah, thank you, Chair. It was just to say I find it really clear and really helpful. And, you know, sometimes these things cover a lot of sheets of paper, but don't necessarily come over as very clear. And I think it is clear, and particularly that last sheet that you mentioned, Julian, in terms of the paper that's going to go out. I think it's really helpfully set out.
Thank you, Karen. And Glenn?
Yeah, I think it does articulate it well. I think the most important thing actually is when our teams see this, our staff see this, that they recognise it as something that they contributed to, which is certainly what I've picked up so far. I think, Julian, that there's just something in my head about the way we balance this out a little bit, because I think previous strategies have been quite heavily branded within the organisation, and whilst I want to see some of those gone, I don't want to be spending much money on a relaunch of a strategy. So it's about how we kind of subtly bring this alongside our staff, because it's something that they've co-produced with us. Have we given that, how we get it out there, some thought?
Only suffices to say, Glenn, the intention would be for us to manage that in-house.
Okay, super. And Stephen?
Yeah, I'll pick up on that a bit as well, because I don't think this is about, I think the similar thing we've always said about the values, you said, Glenn, wasn't it, is we live them, we don't laminate them. I think the key of the strategy is we have a number of conversations. It's not just a kind of a thing that we put out there. It's about how do we have a live conversation that colleagues can understand what we're trying to do. They continue that contribution. So I think for me, there's a bit about how we use a lot of our forums, and probably set some of these up now, Julian, where we we almost do like drop-ins, and we get people just talking about it, and then it just blends into the organisation and it gets moving. But it's really good to see this alongside our patient voice, which we saw this morning, and the values work. It just feels set of things that are all talking to each other, real narrative that people can understand what we're trying to do internally and externally. So really pleased to see it kind of all come together now.
Yeah, and it's got an authenticity to it, doesn't it, Stephen and Julian? It's not sort of full of jargon. It's got it's grounded in reality and grounded in who we are and what we want to be. Julian, thank you for your leadership on this. You've done a great job for us. Thank you very much. Colleagues, happy to move on? We'll move then to some of the board committee reports. I think we've lost Julie Moore, so I'll take the Quality Governance Committee.
I'm here.
Oh, sorry, Julie. Sorry, I thought you'd had a technical problem. Anything you'd like to pull out of your?
We've mostly covered everything today, but I would like to pull out the fact that the long-running estates issues we've had around things like fire and the delivery suite windows are being resolved. And I would like to say that we're seeing significant improvement in estates, and it's thanks to Emma King, I think, who's taken real leadership in this and started to deliver for us. So those issues have not come up today. The staffing and other things have, but we're not where we should be with some of that. But there is a plan, and the committee had confidence that that would deliver. So thank you.
That's great to hear, Julie. And Emma, generally, if you listen to this, you're doing some great work for us over the Alex as well as more generally as Julie's identified. Any questions or perspectives to Julie? Okay, we'll move on then to the Audit and Assurance Committee. I'll take this as read in Colin's absence. Any questions on those minutes? Please raise a digital hand. Tony?
Chair, if I may, as I was at the committee, Colin did want to reference one point, which is under minute 5.1.25. The committee was expressing concerns about bank and agency and job planning, but we've covered those earlier in the meeting. But I thought it was important to say that the committee had looked at those items and referred some matters on. Thank you.
Okay, super. Thank you, Tony, and thank you, Colin, for your work on that. Any other questions or perspectives on those minutes? Now, for members of the public, you'll be aware that the Worcestershire site is subject to a very expensive PFI arrangement, and we are undertaking work to plan for that PFI exit. So we need to look at that subcommittee's terms of reference. Stephen, over to you.
Yeah, so this is the establishment of the committee that we've been talking about to oversee that. Tony and I are linking in heavily as well with Wye Valley, who are also going through a similar process slightly ahead of us. So we brought it together with the terms of reference, and there's a whole schedule of work that's ongoing now that we'll keep bringing back to board. Helpfully as well, we're supported by Lincoln, who works for Swift Clinical Services and previously had a PFI experience as well. So we've kicked this off. There's an awful lot of work to do. I guess for context, going into a PFI and building a new hospital is one of the hugest undertakings you'll take as a trust. And 7 years from now, we've got that huge undertaking and risk passing back over. So there's an awful lot of work that we've got to do, and that's what we kind of talked through. So I don't know if there's anything Tony wants to add, but it's just a kind of signal that we're off on that journey now, planning this through.
That's great, and learning from Wye Valley along the way as well. Questions and perspectives, we do need to approve these. Tony?
Yeah, thanks, Chair. Yeah, echoing Stephen, these are very much modelled on the Wye Valley papers, but we've updated them. Wye Valley are 2 years ahead of us in terms of prep, but also their PFI ends 2 years earlier. So they're in about a sort of similar state in that sense. And I absolutely agree. I mean, the advice we've had is that if the risk transfer out to the private sector about 23 years ago, the PFI was the biggest thing the trust had ever done, transferring that risk back from the private sector into the public sector in 7 years' time is going to be of even greater risk, and it's a job we must get right for the long-term legacy of the hospital and its patients. Our immediate work plan is very focused. I just mentioned 3 things. The first is we're due imminently a visit from the Government's Infrastructure and Planning Authority, who will assess our preparedness for the exit arrangements and also help us to prioritise our plans. So that's a really important step for us. The second really important step we're hopefully about to embark on is the jointly commissioned condition survey of the entire estate and services. Very, very important to get that right, because our expectation will be we'll be handing back a hospital and infrastructure which is in good working order and fit for us to run. And then the third element, just to reference, is that what we've heard very clearly from the Swift advisors and from Wye Valley is resourcing this is a major importance. So part of our early stages will be to get a resource plan developed and get approved by the board. But in the interim, we'll be getting on and doing as much as we can under existing delegation to get that resourcing done. Finally, in terms of memberships, we know the membership of the committees like to alter as we get closer to the date, so we'll keep that flexible. But I'm pleased to say that in terms of non-executive director memberships, both Simon and Michelle had previously volunteered to join this group last year. I've checked back with them. They're both still happy to continue with that. So that'll be our opening set of non-execs on this committee. And our main aim is to make this a great success for the future of the Trust. Thanks a lot.
Thank you, Tony. Important work. I do want to focus on the terms of reference, which is what we are having before us now, rather than the border issues as to how we manage the process of getting the PFI back. But Glenn?
Yeah, it's just that the membership, which I agree with, but also we include within there the ability to try and get some of the national team in, the private finance unit in, to the membership. And I just encourage us to take every opportunity we can to do that, because obviously we are ahead of this in terms of other schemes across the NHS. There's a lot of learning for the rest of the NHS, but they might also resource some of the challenges that we face, so they can create a bit of a template for this. So let's just try and be as open as we can and inclusive as we can with the national team as well.
Yeah, great, thank you. And Stephen.
Yeah, just on that, Glenn, we had that discussion. So I think now we've got the route into those teams. I think through Lincoln we were engaged with them, so we'll have that. The other was around system as well. We were quite open with the system because I think they need to be part of that journey with us as we go through it. So we're definitely not looking at a kind of closed shop. We want to kind of encourage as many as we can to go on that journey with us.
No, great. So on the subject of the terms of reference, if you're not happy to accept these terms of reference, would you please raise a digital hand? Okay, duly signed off. Tony, thank you for your involvement in this with Simon and Michelle. Please keep us briefed as the work progresses, but as we've all indicated, this is a very important thing to get right. Our next meeting's on the 10th of June, because the main meeting is a 4-board foundation group meeting for members of the public. I'd really strongly encourage you to come along to those. They are a little bit different from these, and we do lots of comparative analysis, which people generally find interesting. Have we had any questions from members of the public, Gwenny or Joe?
Not that have been passed to me, no.
Okay, thank you. So any other business, colleagues, please raise a digital hand. Okay, super. Well, what I'll do then is I'll draw the meeting to a close. Suggest colleagues have a 5-minute comfort break, and then we'll get back together again in the next meeting for the confidential board. Ladies and gentlemen, take care. Thank you. And to colleagues on the front line, thank you for your hard work. Take care.